Welcome to SOHO Spotlight, a podcast by the Society of Hematologic Oncology featuring top experts from around the world sharing practical tips and strategies on the management of hematologic malignancies.
Hi, and welcome to the first episode of SOHO Spotlight. I'm Nicholas Short from MD Anderson Cancer Center in Houston, Texas. And today we're going to be talking to Jae Park, Chief of Cellular and Therapy Service at Memorial Sloan Kettering Cancer Center in New York, about optimizing outcomes in adult acute lymphoblastic leukemia with CAR T-cell therapies. This podcast episode is supported by Autolus. So welcome, Dr. Park.
Well, thank you for having me here, Nick.
Great. So to start, we're going to be talking about CAR T-cell therapy. Now, this is really changing the outcomes of patients with relapsed and refractory B-cell ALL, leading to better outcomes for these patients. Fortunately, now we have 3 different products approved in the US. So in this conversation, we're going to dig into some of the practical aspects about delivering these therapies to our patients. So just to start, tell me, who do you consider to be an appropriate patient for these CD19 CAR T-cell therapies? And related to this, when should patients make these referrals?
Currently, the CD19 CAR T-cell therapy, we have 2 approved products, brexacaptogene and obicaptogene as well. Both of the products are approved for patients with relapsed or refractory B-cell ALL. I'll consider relapsed patients or refractory patients, including those patients who have MRD or measurable residual disease positive patients, meaning less than 5%. Because if you have several cycles of induction or relapsing after achieving a MRD negative remission, even with an MRD positive, these patients are clearly destined to have a morphologic relapse later on. So these patients are also be appropriate for consideration for CAR T-cell therapy. So that is current FDA approved indication for adult patients 18 and older. I think in terms of timing of referral, I think that's critical. I think you and I both see some patients who do get to see us too late after receiving all conventional chemotherapy and every immunotherapy, blinatumomab and inotuzumab, and maybe any others. And those patients are challenging because in these autologous CAR T-cell therapy, we collect the T-cells, need to think about some bridging therapy. And we do know the outcomes are better when they receive CAR T-cell with a lower burden of a blast, which we'll get to a little bit later on, and stable disease. But the more therapy they have, more refractory disease they have, we simply have less tools to control their disease, and their outcomes post-CAR T-cell therapy may not be as optimal as it could be. So getting these patients early, thinking about CAR T-cell therapy early and making that emails, phone calls, or texting to neighboring CAR T centers, I think that is critical.
I'm interested because actually you mentioned MRD. And so I guess, technically the label says relapsed refractory B-cell ALL. I'm just curious, do you have any issues getting that for your patients who have persistent MRD?
Luckily, fortunately, I think in the US, where obviously where both of us practice, has been good. And I think the most in doctors in the ALL community and recognize a persistent MRD as to be refractory disease. I think that some of these definitions in the future for what the refractory disease may change also. But luckily, I have a lot of issues getting the CAR T-cell product approved for low burden patients or MRD positive patients.
Great. Okay. So we have a few different CAR T-cell therapies approved. As I mentioned, there's 3 different approved in the US. Can you talk a little bit about the different CAR T-cell therapies that are out there for ALL? How do they differ in terms of their administration? Any data on, big differences in safety or efficacy among the different products?
Yeah, so luckily we have 2 approved products for adult patients with the relapsed refractory B-cell ALL. The first one was brexacaptogene, which is targeting CD19 with CD28 co-stim domain. So design is a little bit different than the second product which we'll get to. It works very well, and both in the second product is obicaptogene, also targeting CD19, but with a different binder, different co-stimulatory domain. This one has 41BB, and obviously both of the products have a different manufacturing. The great news is that both of the products actually work very well in terms of getting initial CR or CRI or overall response rate in the ranges of 80%, which is pretty incredible in these relapsed refractory patients, including the patients who have had prior blinatumomab and inotuzumab. The administration schedule, which we'll get there first, both products both require lymphodepleting chemotherapy with the fludarabine and cyclophosphamide. Schedules are slightly different for both products, but the drug itself is the same. The brexacaptogene is a one-time infusion on day 0 or day 1, kind of one-day infusion. Obicaptogene has a 2 split dose infusion on day 1 and day 10. So that is different between the two products there. Safety profile is probably what is differentiating between these two products the most. Brexacaptogene, which is earlier CD19 CAR T-cell product that was approved that has similar side effect profile as what you and I've been used to getting into early development of a CD19 CAR T-cells, including for pediatric patients with a severe cytokine release syndrome or severe neurotoxicity rate, including seizures. And about 25% of the patients experience such toxicity in the severity degree requiring ICU level of care. Obicaptogene, one thing that has been different is that we now have what appears to be a very safer product, and a quieter CAR, kind of so to speak, in a way that they don't have as much incidence of a severe CRS and neurotoxicity in the 3 to 5% ranges, dramatically lower than 25%. So these toxicity, yes, we still do see. And low-grade toxicity, we can also see that as well. But the severity of side effects that we are encountering these days with obicaptogene or the newer product has been low, which then allows us to use this product in those patients that we previously maybe didn't think it was feasible or possible, didn't think it was a good candidate, including older patients or younger patients with comorbidities. So in my opinion, it opens the door to a wider group of patients and even thinking about them in earlier line of therapy.
Just for completion, what about the tiza-cel, which is really mostly for pediatrics? But how do we think about that relative to the profiles of these other ones?
Great question. So the tiza-cel, which is approved for pediatric patients and younger adult patients, there are two side effect profiles are similar to, in some ways, brexacaptogene as well too. So they do a similar high initial response rate of, again, about close to 80%. But severe CRS, severe ICANS, or again, the neurotoxicity rates are still in the 15 to 20% ranges in pediatric patients too. So that's similar to, again, what we were seeing previously in tiza-cel and brexacel.
Okay, so now I think one of the questions is, let's say we have a patient and we give them CAR T-cell therapy. I think a big question is always, is this it? Or are we just going to watch the patient? Do we need to bridge them to stem cell transplant? Obviously, it's a complex and probably individualized decision. But how do you make that decision? What are the factors that play into that when you have an individual patient in front of you?
This is probably the most difficult and kind of the challenging questions, and we wish both of us have a better perspective, stronger data to guide us. So we make these decisions based on kind of what we know and what we have seen through subgroup analysis of a prospective clinical trial and some retrospective analysis and real-world data. So it is somewhat individualized data there too. So the patients that I feel probably the most comfortable without recommending immediate consolidated bone marrow transplant are the ones who had a prior transplant, which we do know that these patients, not only they don't do as well with the second stem cell transplant, there are also data to suggest that multivariate analysis, again, not a prospectively validated data, but these prior transplant patients tend to have a more durable responses. So if they have a prior transplant and have a lower disease burden, the bone marrow blast, certainly less than 5% that we consider them to be low, but even to be honest, 5 to 20%, I think these are also favorable disease categories as opposed to 70% to 100% of a bone marrow blast, which we do know tend to have a very short duration of a therapy. So patients with low disease burden, prior bone marrow transplant, and they achieve NGS MRD negative CR after CAR T-cell therapy, either at 1 month or by 3 months. These are the patients that I will watch with close monitoring without proceeding immediately to consolidative transplant. The ones I do worry are the opposite patients who have very high burden patients, like 80 to 90% bone marrow blast, and were fortunate enough to achieve NGS MRD negative after obe-cel. I think these are the high risk patients that we do kind of consider for kind of the stem cell transplant afterwards. And there are patients in the middle that we're trying to make the best decisions, kind of based on the information that we do know for what other tools we have, if they were to relapse, some of the pH positive patients that we have some TKI maintenance that we might be able to try to lengthen the durability of a remission. There's some ongoing data collection in that regard. So I think, but having said that, that's a kind of the challenging population. But lastly, I will speak that with an obe-cel, and we always wish that we have a better biomarker to decide who we can, do or not. And there are these clinical factors that I just mentioned before about their presenting disease burden, prior transplant, maybe Philadelphia chromosome status, prior treatment history, whether they were refractory to blin or INO before, are all helpful. And NGS MRD negative after transplant is also very helpful measures to decide whether they need a transplant or not. But at least with an obe-cel, and the CAR T-cell persistence has also been associated with durable remission. We don't know what percentages might be good. It's kind of a good target. And then how long do they need to stay there? But there's beginning to be some biomarker and more research needs to be done, hopefully to help us guide that these patients may be able to avoid consolidated transplant afterwards. Interestingly, CAR T-cell persistence doesn't appear to be a kind of the prognostic indicator for brexicaptogene. So it may not matter for all CAR T-cells, but at least for the obe-cel, it came out to be.
Great. And so let's talk a little about how delivery of CAR T-cell therapy is evolving over time, kind of where you see it in the future. So, are we ready to move to outpatient therapy? Should these patients get admitted, or can we do this as an outpatient? And also, what challenges remain, I think, specifically related to access to CAR T-cells, and can they be moved to smaller volume centers?
Yeah. So I think the first topic of outpatient versus inpatient, that we used to do all this CAR T-cell therapy, including lymphodepleting chemotherapy, the flu-cy that we mentioned previously, as inpatient. Mainly because they were getting CRS within 24 hours, and most of these CRSs are high grade or moderate grade. They require kind of the inpatient monitoring. With the newer generation CAR T, including obe-cel and other CAR T products in the other disease subtype, because the onset of first fever is several days later, and then the degree of a CRS and neurotoxicity also lower than previously, we're now beginning to administer more and most of this CAR T-cell therapy as an outpatient, if, again, the patients are certainly medically appropriate to do so. But now it allows us to think about outpatient versus inpatient, where previously it was almost always inpatient. So that is a big change. It's good for the patients. They don't have to sleep in the hospital bed, spend less time in the hospital. I think that's a good finding. The second question about the access, I think is probably one big issue in my mind that we continue to deal with. It is sometimes mind-boggling that we have this potentially curative therapy, and if not curative, very effective therapy with durable remission, probably best of any other tools that we have for some of these patients. Yet fewer patients are still getting CAR T-cell therapy. And there used to be good reasons associated with high toxicity, specialized centers. You need to stay nearby these centers used to be 28 days, but now without REMS requirement, it's getting shorter and shorter, and at 14 days and even shorter for some products. So I think hopefully these things are making it easier. But I think that's the point, that the message do need to go out there, that we have a effective therapy, now a safer therapy. At least we want to consider for CAR T. And I fully recognize not everybody needs them and may benefit from them. But for those who do, we want to see them early and make decisions earlier than later, and take them to CAR T-cell therapy where we can actually make the biggest difference, and then hopefully the curative potential, and avoid bone marrow transplant. Is when we get these patients so late and then have a high burden disease, we barely were able to get to CAR T, and then we still have to get to transplant because their disease was not optimized before CAR T-cell therapy.
Yeah, I mean, I think hopefully we can improve access. I think it's a challenging question how to do that, but I think obviously, as you mentioned, these are very effective therapies. I hope that they can be available in the future to all the patients that need them. And then so more broadly, what do you think about the future of CAR T-cell therapy and ALL, specifically in terms of where it should be positioned in our treatment algorithms? So we've already talked about giving it for MRD positive disease. What about in frontline consolidation, for example? Where do you think, 5-10 years from now, where are these therapies going to be placed in our algorithms compared to where they are now?
Yeah, I think it's certainly a very exciting time, and to see such many other effective therapy in ALL and trying to figure out where they kind of belong. I think the biggest potential that I do see with this type of a cell therapy, CAR T cells, is ultimate limited duration of a therapy, and I think we have a biggest chance of a cure with least amount of a treatment with this type of a treatment. So where I do see it moving forward in the frontline setting. And some of us are, including your centers and our centers, are investigating this exact question in early lines of settings. So, for example, for those patients who get induction and maybe a cycle of a consolidation in 3 months or within 6 months of their initial diagnosis, and that they can, most of these patients achieve MRD positive or MRD negative response, and then they get CAR T cell therapy, and then watch these patients without subsequent transplant and see whether we can cure most of our ALL patients with 6 to 8 months of a treatment, and hopefully shorter, even shorter than that, as opposed to current length of therapy, which is often 3 years of a treatment, multi-agent chemotherapy and maintenance that is required to do so. So I think that's where things are moving. Now that we have such a powerful, potent treatment, can we replace blocks of a chemotherapy with the transplant and with CAR T cell therapy without needing bone marrow transplant afterwards, and then cure such patients? And the other, really, the benefit of a CAR T cell therapy is that they do traffic to CNS space and central nervous system, and they can provide CNS surveillance. So we may not need to do all this intrathecal chemotherapy, and some regimens have 15 to 20 intrathecal chemotherapy for kind of pediatric regimen and others. It's a lot of lumbar punctures that our patients have to go through, but if we can make it successful, that it can provide those ongoing CNS surveillance, and may even reduce the number of lumbar punctures and spinal tap these patients need to go through. So I think the front line is where we should go, and hopefully we can actually make it prove that it's successful and effective and safe for these patients.
Great. Well, I think you've highlighted that these are very effective therapies, and I think it's very exciting to think about how we can optimize their use in the future and hopefully cure even more patients. So with that, Dr. Park, thank you very much for joining me for this discussion.
Thank you for having me again.
So all of you watching, you can find the links for additional CAR T-cell related resources in the show notes. Thank you for listening to this podcast. If you enjoyed the conversation today, please consider subscribing to the channel on your favorite podcast platform or on YouTube. And also please join us at the SOHO 2026 annual meeting for more on this topic. You can register today at www.soho.click/register. SOHO members receive 40% off registration rates. And thank you again for joining us.
Thanks for listening to SOHO Spotlight. For upcoming episodes and more educational resources, visit sohoonline.org and click on the Education tab. And because we believe high-quality education should have zero barriers, SOHO membership is completely free. Become a member today at sohoonline.org and stay current on the latest in blood cancer research and care.